Well, hello everybody. I wanted to put up a new video today explaining some of the methods that are used in our office to help with acute and chronic pain issues. And today I wanted to cover a topic that is one of my fun and special interests, which is in regenerative joint therapies. These are techniques that have been around for a long time, and yet it's been more apparent in the recent decades just how effective these older approaches to healing tissues can be. It's often comes up in conversation about what prolotherapy is. What sort of circumstances would it be beneficial? And they've read about it. They may have read about stem cells. They may have heard about it from friends or something in the media. Several years ago, one of our colleagues at an academy meeting in medical acupuncture had presented a topic entitled essentially "What to do if acupuncture doesn't work? What do you do next?" And that had been an issue many years ago. After learning about acupuncture, there were certain pain problems that presented where some improvement was certainly noted with neuromuscular acupuncture, more advanced techniques in orthopedic approaches with acupuncture. But some areas that may not have responded turned out they were often areas that were pinpoint areas of attachments, anatomically speaking, where ligaments, where fascia was connected onto bone, essentially surrounding joints, providing stability to joints. So when back years ago I was introduced to the techniques that were pioneered by George Hackett, Gus Hemwall, and others, these were providers back in the 40s and 50s, surgeons actually, who found very helpful to inject areas with stimulants or injectant solutions, essentially materials that would provoke the patient's own healing mechanisms to come into play and essentially help heal up the area of trauma. So without getting into too much detail, we're talking about an area that globally, when somebody talks about prolotherapy or proliferative therapy, could include any number of solutions that are injected specifically into pinpoint areas, zones, locations that anatomically make a lot of sense in orthopedics, in pain management, physical therapy, and many other fields, osteopathy, where you find what one of my teachers, Jeff Patterson, would refer to as the weld point. Weld as in welding metal plates together. But these are areas where connective tissues attach onto bone, and not uncommonly that is where patients will feel their pain if one is careful to do a proper exam and very carefully finding these areas. You'll often find these link up with spots that they continue to identify as their pain triggers. So today I wanted to help hopefully answer some questions that come up often in clinic is, would this be a potential treatment for me? If I have referrals, this is sometimes what we discuss at first visits. I often inherit patients from very advanced either physical therapy or other pain management offices where most of the work has been done, but what's apparent is that there may be joints or described as ligament laxity, where ligaments may have gotten injured over time or traumatized over time. And what can happen is those ligaments don't maintain their integrity. I kind of think about it like a rubber band that's been overstretched. We've all found rubber bands in the back of a drawer that are years old, and they don't have the flexibility. They don't necessarily tear, but they don't have the flexibility. Well, think about ligaments that hold joints together, providing stability to the joint. If those areas have been traumatized, injured, or just from aging or wear and tear, they may not have the resilience that they used to have years ago. Many patients may have identified traumas that indicate when that first started. Interesting to think of a disc herniation in the axial spine. So the discs that are between the bones, imagining that disc is compressed, essentially it's a weight-bearing joint, But if those vertebrae, those backbones, aren't properly stabilized, they may unfairly be compressing that disc because of loss of stability that's inherent to maintaining a neutral axial spine. So I think about disc herniations and other pain problems much differently than I used to after finishing medical school and residency. What type of solutions may be used? Well, there's still a ton of work that we do with dextrose. Dextrose is an inert sugar, but it acts as a local irritant. The dextrose comes packaged in bottles that can be drawn up in different concentrations and injected into specific zones. Many have heard of plasma, or platelets, I should say, PRP, platelet-rich plasma, which actually comes from the patient. The patient has blood drawn, and through a series of techniques that blood is spun down, and the plasma, which essentially contains a larger number of platelets, as well as growth factors that help stimulate tissue healing, are then reintroduced through injections into those same areas that have been injured or traumatized. Some use stem cells, also collected from the patient in different ways. And then there are even more advanced approaches, including tissue derivatives from places like amniotic cells or amniotic fluid. So there's many more orthobiologic substances out there available. I wanted to focus today mostly on platelets and dextrose as both areas that I include as part of my prolotherapy approaches in the office. I wanted to focus on one area. This is a common one to not uncommonly be walking in the door, common where patients will identify their low back pain, and they'll make a fairly common shape, and it's right over their low back. And what they're pointing to is the area over the sacroiliac margins on either side, one or the other sides, where the lower lumbar spine makes a connection with the pelvic bones. And not uncommonly, either my chiropractic or my physical therapy or osteopathic colleagues describe a laxity where they will have the patients come in, and then the next time they get checked out, they may have the same area that feels like it's loose or it's moved again. Well, those may be considerations potentially for prolotherapy if strengthening with physical therapy and other approaches haven't been completely successful. Folks will ask, well, what if I don't want to do prolotherapy? Is there any other way I can determine if that's the area where my pain is coming from? And the answer, in a few patients that I've worked with, we may test the theory and potentially inject the area with simple things like lidocaine or long-acting Marcaine. I don't necessarily use steroids to help answer that question, but if that area, the joint or the ligament where it's attaching to bone, is the triggering mechanism that causes their pain, you can sometimes do this as a diagnostic and therapeutic trial by injecting those anatomical landmarks with simple things like lidocaine, and seeing whether or not it makes a difference with the patient's pain, even if it's for a short period of time. And I've done that not too infrequently, and if it is, that may be to be considered an area where prolotherapy can be carried out. What I enjoy about prolotherapy in general is the fact that it's using the patient's own healing mechanisms that we already have. It's not putting something completely foreign into the body, but it's creating a natural stimulus for the body, very similar to what happens after, for example, when somebody sprains an ankle and the classical quote-unquote goose egg on the outer part of the ankle forms. That's a result of inflammation, but the good thing is that inflammation is actually a good thing. Unfortunately, over the last few decades, with availability of anti-inflammatory drugs like ibuprofen and Aleve, ketoprofen, these are they're great for short term, even steroids. They're great for short term, but unfortunately they've been found to inhibit healing. They get in the way of the natural inflammatory cycle, and many feel that that might have contributed to an area that didn't quite heal all the way. So with that, we introduce solutions into these areas to try to help it mend in case those joints or ligaments continue to be overly lax, or the joint continues to not be well maintained. Getting back to an area that I see on a fairly frequent basis is low back pain, as I mentioned earlier. And mentioning again the sacroiliac joint, I used to think about the sacroiliac joint as a simple joint between two bones, and come to find out it's a very complex, not only is it a joint, but a very complex series of ligaments. And I wanted to show you a diagram, if I can flip screen here, to a diagram out of Primal anatomical resource for imaging. But this is essentially a makeup of the lower back. This is the lower spine, the lower vertebra, as it connects up with this bone that's partially buried in ligament, which is the sacrum. All of this purplish gray material, all of this, all on either side, even at the tip of the sacrum down to the tailbone, this is all ligament. These all have names and function, but you can see that this ligament heads all the way down to the sits bone, or the ischium, part of the pelvis, that if we're sitting on a bike saddle, that's right where that bone is. But patients sometimes will actually point to this trajectory of where these ligaments live and say, that's where my pain is. Another very important ligament sits between the pelvic bone here. This is the iliac crest. You'll see these structures that are closer to the spine, and these are parts of the iliolumbar ligament. So on either side, we have these, what I call outriggers, that connect to the lower fourth and fifth vertebra to the part of the bone we call the innominate bone or pelvic bone. These are stabilizers. So if I have a patient who has a fourth or fifth lumbar vertebrae that wants to slide, rotate, and have instability, I need to consider joints like the facet joints, the iliolumbar ligaments, and also see how the sacroiliac joint ligaments play into stabilizing this whole lower lumbar column. So this is to give an example of why, with comprehensive prolotherapy injections to the lower back to treat instability, why many of these structures are considered to be very important. It would make sense when you look at a diagram like that, where a simple steroid injection just into the joint only on one side where the patient is symptomatic may have a short-term benefit, but it won't take care of the entire right and left side and the whole, what we call integrity of a joint to stabilize it. All of that needs to be considered for treatment. And one of the organizations where I've received my training at the Hackett Hemwall Patterson Foundation for many years has trained us to incorporate injections that would include all of those areas if necessary to help maximum stability. Steroids are sometimes used, but less and less frequently, and we have found over the last number of years, we have realized with research that steroids, though may be effective early on and short term for pain management, unfortunately they've been shown to be potentially destructive and damaging to cells that make new collagen, that make new cartilage, essentially the materials that we're trying to generate with prolotherapy. We may actually be causing damage over the long term by using steroids. That is a discussion to have with your provider, and there are rare instances where sometimes I will still use steroids, but much more I'm enamored with what dextrose, what platelet-rich plasma can offer as a healing tool for patients when it comes to helping with their chronic joint or ligament injury pain areas. So I'm hoping that this helps to explain a little bit about prolotherapy. On my website, there are links to the Journal of Prolotherapy that gives a little bit more background about where it all came about and discussing PRP or platelet rich plasma, which is a very potent and strong tool, which I've been finding extremely useful, to be as a consideration for patients who may be considering non-surgical methods to helping with their healing. I hope you have found this to be useful, and I appreciate you watching. It's always a pleasure working with you all, and I hope this is resourceful and helpful if you're trying to decide maybe if prolotherapy is right for me. And always, as always, if there's any questions, you can reach out to our office and we can help answer some additional questions if you have them. So I wish you a wonderful afternoon, and we will see you soon. Take care.